Thank you. I guess I probably should remain behind this mic to make sure there's good sound for the recording and transmission, so I will remain here, which is usually tough for me to stand in one place. Just confirming I have 15 minutes minus 30 seconds, is that correct? 20 minutes, oh, okay. I'll try and get done in 15. As a habit, I tend to talk fast. So I was asked to talk on key elements in formatting discharge instructions. And first must say I'm very honored to have the opportunity to present to the Health Literacy Roundtable. I've been absolutely thrilled that this group convened and is making so much progress in this area and bringing attention to something that's been near and dear to my heart since the early 1990s. I'm going to spend a little bit of time not talking just about the healthcare provider to patient discussion, but also healthcare provider to healthcare provider, because I think this is also critical in that we're a team trying to care for patients and working with them. So the objectives that were assigned to me were to describe the key elements that should be included in the inpatient discharge summaries, and this is this provider to provider component that actually I believe should be shared with patients. And so I'm going to talk a bit also about my personal experience and what I do when I take care of patients by myself as a hospitalist, and then describe the formatting techniques that can improve readability for patients. And again, a little bit of this is experiential or anecdotal, and like many here feel there should be more research in this area. So I suspect a lot of you are aware of these new conditions of participation that came out from CMS. I think this will influence what happens around the entire hospital discharge process. I was fortunate to serve on the technical expert panel for this, along with Eric Coleman, Steve Jinks, and some others. The meeting occurred over 2 years before these came out. I'd sort of wondered what happened, and then suddenly I heard this existed and was quite happy about it. Now, they talk about these conditions of participation around discharge planning, and there was this discharge planning guidance revision published in May of last year. Must have in effect a discharge planning process that applies to all hospitals. This is the responsibility of hospitals. So again, hospitals must have in effect a discharge planning process that applies to all patients and have it specified in writing. And then there are multiple interpretive guidelines. Hospital discharge planning, a process that involves the appropriate destination for the patient, requirements for smooth and safe transition. Sounds wonderful. So I'll try to do a little explanation of this, and this is almost how I felt when I saw all these guidelines and then there were the interpretive components, which means, well, what are we supposed to do? And the inspectors aren't required to necessarily interpret this, and it leaves a lot up to chance. It reminds me of what patients are supposed to do when healthcare providers in the hospital are explaining what they're supposed to do after hospital discharge. So while hospitals are not solely responsible for the success of their patients' post-hospital care transitions, woohoo, I was thrilled to discover that they realize this now. The hospitals are expected to employ a discharge planning process that improves the quality of care for patients and reduces the chances of readmissions. I'm also excited about this. I think historically, if you actually watch a hospital discharge process, it's recognition that, oh, we can get the patient out of the hospital today. Do they have transportation? Let's get them their instructions and get them on their way. We conducted a qualitative study, it's now been about 6-7 years ago, where we audio taped the complete comprehensive hospital discharge interaction between the patient and a pharmacist, nurse, physician, etc. It lasted a whopping 8 minutes on average. So there's now guidelines from Medicare that you have this 4-stage discharge planning process of screening patients, which I think is critical, that you identify who's at highest risk of adverse health consequences post-discharge. You then evaluate their post-discharge needs, develop a discharge plan that encompasses and includes consideration of these factors, and then you initiate this discharge plan prior to discharge. And if you talk to any case manager, they'll commonly quote to you, hospital discharge planning begins on hospital admission, as it probably should, but it typically doesn't. It happens often on the last day. There's this big, thick sheaf of papers that are given to patients, and then there's the obligatory question to the patient and their caregivers, any questions, or do you understand? And you know the responses to that. Now, interestingly, in these guidelines, it says there should be input from medical staff, post-acute care facilities, patients, and advocacy groups as you attempt this discharge planning process. And I'd be very curious how many hospitals have actually done this, where they integrated all these aspects into the discharge planning, but I think this is absolutely necessary. Now, what I want to touch on now is this component of hospital care provider to the community provider, because this is essential in what happens in the patient's management. And historically, that communication has been absolutely abysmal. This was a systematic review that a group of us conducted. Now it's been quite a few years ago. It was published in 2007, so this occurred over 8 years ago when we did the work, when we reviewed the literature. This was a collaboration between the Society of Hospital Medicine, the Society of General Internal Medicine, and Sunil Kripalani, who's now at Vanderbilt and a leading health literacy researcher, was the lead author. And we found out that there was little direct communications between the hospitalist or hospital provider and the community. Discharge summaries were commonly not available at post-discharge appointments. And I can confirm to you that still the Joint Commission requires that discharge summaries be done within 30 days. Isn't that wonderful? Has not changed. We strongly at this technical expert panel meeting with CMS tried to insist that this should be changed, and it should be more in the 24 to 48 hour range, in my opinion. And even when discharge summaries are completed, they often lack a lot of the information you can see here. You know, the percentages, they're almost staggering. One of, I think, the leaders in development of health information exchanges, Indianapolis, has all their information available to all their local hospitals and community providers and so forth. And Martin Wary actually worked for me as a hospitalist back at Emory many years ago, did a medical informatics fellowship there, and he began to look at the discharge summaries that were in this system. So access wasn't the issue, but there was still this problem that they were grossly inadequate at documenting both the tests with pending results and appropriate follow-up providers, as this information was going from the hospital to community providers. I think there are good principles around transition of care out there. This is something we published a long time ago. It seemed like a lot of work and effort, and when we published it, I didn't hear a peep. I have since begun to hear more and more as people discover this article, and I would refer you to it. And I think the best aspect of this publication is that it involved so many specialty societies trying to come together, from general internal medicine, geriatrics, emergency physicians, and hospitalists. Importantly, and I think this was a huge mistake, we did not have patient groups involved in this. But I think the principles are still important and ought to drive a lot of what we do when we're trying to communicate, that there's accountability for what's happening to the patient as they transition through the system, responsibility, and the patients know who they can contact both at the hospital and as they're transitioning. There's coordination, family involvement, a timely communication, and then these national metrics and standards. So we have to be very careful that these national standards and metrics don't drive what can be often inappropriate care or inadequate instructions to patients. So I began to look into this a little bit, and there's been a lot coming out to help patients. This Your Discharge Planning Checklist was generated from CMS, and I think it's a nice summary of some of the things that ought to happen. This is for patients to use, but it also brings up some of the aspects that make this difficult, in that a lot of patients are faced with, if you will, having to figure out what should happen instead of this collaboration between the providers and the patients and their caregivers. And so it talks about the name of the patient, their reason for admissions, these instructions for them to use this handout. Has a number of action items about what's ahead for them, what to look out for their health, how to notice if there's going to be an emergency, how do they respond, recovery and support, both in activities of daily living, maybe interacting with social workers, and information also for the caregiver, which I think is important. And then they have all these checklists, and it implies that you should take this into the hospital when you're hospitalized and check things off. I would state that a lot of times patients don't have a lot of planning when they suddenly get ill and call 911 to be transported by ambulance. The first thought isn't, oh my goodness, let me make sure I get my discharge checklist in my hands as I go. And then there's also nice items to prompt the hospital staff. to make sure that they review this with the staff and so forth. I've taken care of lots of patients. I've had lots of hospitals who work for me who take care of patients, and I've not heard any of them comment on patients bringing this in to the hospital, and we certainly don't help patients do something like this typically. And again, more checklist actions items. I'd like this, though, information for the caregiver. Nice drug list, my appointments, nicely laid out. I think is something maybe what we should be striving for in electronic medical records. ARC has their own. They're taking care of myself guide for when I leave the hospital. Again, very good information that might be able to inform what we ought to be doing. Again, to me, this leads us a little bit to interpretive dance. So here's my obligatory cat picture. So as was mentioned, Eric Coleman had a nice grant, and we began to look at what do patients actually understand, and then can they execute it when they get home. And we found out that health literacy and cognition, and I think these are very tightly tied together, as you're well aware, and self-efficacy predict successful understanding and execution of instructions post-hospital discharge. Importantly about this study is that patients were interviewed after they'd gotten home. Now, fascinatingly, neither the discharge diagnosis nor the complexity of the instructions actually was a significant predictor of outcomes. And so we believed from this that there need to be reliable protocols that identify patients at high risk for poor understanding and execution of their discharge instructions, and then we need to have customized approaches for them. As part of actually an ARC grant I received back in, I think it was around 2006, I worked with patients in the hospital to try and develop simplified discharge instructions, because that's what I felt was needed as a physician when I was communicating with patients, and the nurses said they needed this too. And so we came up with something called the Discharge Patient Educational Tool, and you can actually search this on the web and it pops up. It's on the Boost website. We basically integrated it into the toolkit. And it is laid out in a very structured manner for patients with their name, their admission date, discharge date, days in the hospital, because that was important to us and them, who their primary care doctor is, who is their hospitalist doctor while in the hospital, and then other doctors and the specialties that consulted while the patient was in the hospital. And then very patient-centered approach to them explain their instructions. I had to stay in the hospital because the medical word for this condition is, there's good literature showing patients want to know the medical terminology and the medical leads, they just want to know what it means. And then I also have these medical conditions. And then the tests. While I was in the hospital, I had these tests which showed, while I was in the hospital, I was treated with particular treatment, the purpose of this treatment was. So very patient-centered, structured approach to common aspects of factors or issues that patients want to know about. Then there are follow-up appointments, follow-up tests, call your primary doctor for the following warning signs, lifestyle changes. We worked very hard and got this down to 1 page. For Boost, we even came up, this was 2 pages. We came up with a 1-page one for Boost, another form called PASS to make it even simpler. And the fascinating thing as we began to implement this is when nurses used this form, they immediately found patients reacted very strongly and positively. A common comment was, why haven't they done this in the past when I came in the hospital? Now, when I thought, aha, I'd struck gold, I then tried to get this integrated into the electronic medical record. I started this in 2007. I agreed to head a 6 Sigma project to improve the hospital discharge process at my new hospital. It's now 2014, and I still have not seen this integrated into an electronic medical record, and this is even working with the EMR provider. You would think something you can do in Microsoft Word could get translated to an EMR. Boy, has that been a lesson for me. So what I'll stop with is we need to figure out what patients should do in this environment where our EMRs are very good at generating 10, 15, and I've seen 25 to 30 pages of instructions when I hit print. It's not formatted. When I ask why can't it be formatted, I'm told, oh, because. And I think this is what we have to figure out. Because honestly, while you can come up with something simple and straightforward off of your computer, we're now obligated to use the EMR, and we've got to figure out how to get this out to the community, where the patients are. And I'll stop there.
Lovely. Thank you, Dr. Williams. Can we just do a little reconfiguration of the room and have the next three speakers go to the front table? Drew and Lila will assist you with that. And since we have a moment of time to fill, why did it take that many years to not get the document into the EHR? Mark, why did it take that many years to not get the document into the EHR? Just to put a point on it.
You can do it. Would you rather sit?
So initially, we attempted
You can sit
to
over there.
use the customization capabilities of the EMR, and I worked with a coder. And we invariably would encounter issues such as the EMR did not have the capability for expanding tables. So there might be 1 or 8 or 9 important tests that a patient underwent during their hospital stay, and it didn't have that capability. And so there were all of these logistical issues that were just simply limited by the EMR, and it kept being referred back to, we have to let the vendor try and work on this. And I've actually gone to the vendor, and the vendor is integrating some of the Boost tools, and their comment regarding the discharge instructions were, that's a different team. They've recognized that our current method, which was developed to meet meaningful use criteria, and so there's intense interest in not losing the meaningful use criteria ability. They need to rebuild it and reprogram it, and I was told that'll take 2 or 3 years, and that was last year. So I think eventually we'll get to that point, but it is impressive how the EMRs or companies are now controlling so much of what's happening in hospitals as they attempt to meet the meaningful use criteria.
Sure. Thanks.
Often in the stupidest possible way. Excuse me, I have to say that.
Thank you.
It isn't actually required to implement meaningful use criteria in a stupid way, but it often is done. I can't resist.
All right. Thank you. And we will not introduce that speaker. You're welcome.